good afternoon, everyone that's here in person, and those that are attending virtual, welcome to Pulmonary Critical Care and Sleep Medicine Rounds. I'm Dina Costa, for those that don't know me. I am delighted to introduce Dr. Ella Christoph. First, before I get into the introduction, I do just want to take the time to thank the Pulmonary and Critical Care fellow candidates that have been interviewing who may be attending virtually. Welcome. We're happy to have you join us. So I have had the pleasure in the last about year and a half working with Ella, who has had a very interesting background getting here. Ella completed an English Bachelor's of Arts at University of Chicago, and recently told me a story of how she became interested in medicine. It was when she was working as a research assistant during her English degree for a researcher at U Chicago, and she was going into NICUs and adult ICUs, asking clinicians to prognosticate on whether that patient would survive or not. And that was really when she began to become interested in both medicine as well as sort of patient and family engagement and interacting with patients. She completed her medical degree at New York Medical College, which ironically is where I grew up in Valhalla, New York. She did her residency in internal medicine at University of Michigan, which is where I was before I came here. She actually was awarded the Most Outstanding House Officer Award at University of Michigan, which I think is quite notable. She is currently completing her fellowship at Yale, and she's been working with my team doing work in qualitative and quantitative methods to study ICU teams and patient and family engagement. So she's going to take you on a wonderful journey for the next 45 minutes. Some quick housekeeping. If you're on Zoom and you have questions, you are all muted, so please use the chat function. Once Ella finishes, we'll have about 15-20 minutes for questions, and I will come around with the mics for you all to use that. So please, let's welcome Dr. Christoph.
Good afternoon, everyone. I think I know many of the faces in this room, but for those who I'm meeting for the first time on Zoom, nice to meet you. My talk today is entitled Method to the Madness, Methodological Approaches to Making Sense of Family Engagement in the ICU. Here's CME. I have no disclosures to report. So today we're going to talk a little bit about how family engagement is currently positioned in the ABCDEF ICU bundle, delve into the literature a little bit to understand how we've gotten here, and discuss some of the qualitative methodologies that are the foundation of much of the research in this space. So most of us here are probably familiar with the ABCDEF ICU bundle, which identifies evidence-based practices to improve ICU care. A for assess pain, B for daily awakening and breathing trials, C for thoughtful choice of anesthesia and sedation, D for assessment, prevention, and management of delirium, E for early mobility, and F for family engagement and empowerment. But to give a little bit of history and context on the bundle, it was first created in 2013 by the Society of Critical Care Medicine to facilitate implementation of these objectives. There was evidence for all of the components except for F, and that evidence actually dated back from 2000. So there was a robust body of evidence for everything but the family component. In 2014, SCCM was awarded a $769,000 grant from the Gordon and Betty Moore Foundation to study the bundle across 68 American ICUs over 20 months. And initially, the F component was not in their proposal, but as a part of the grant, the foundation emphasized moving toward a more holistic and patient-centered approach and recommended that the study include family members, which prompted the addition of the F component to the bundle. In that study, the F component meant that a family member was educated on the bundle and participated either in rounds, in a conference, in the plan of care, or participated directly in bundle-related care. And the first editions of the F as for family engagement to the bundle that I could find in the literature dated back to 2016 in papers out of Wes Ely's work at Vanderbilt. So when we look at what is in the SCCM ICU Liberation Bundle today for the F component, it is grouped into an introduction, assessment, and interventions, which includes things like flexible visitation, daily meetings, interdisciplinary rounds, and family participation. But where did these recommendations come from? In 2017, there was a scoping review of 638 qualitative studies to determine PICO questions related to the topic of family-centered care in adult as well as neonatal and pediatric ICUs. There were 238 studies that were randomized controlled trials or observational trials that were used to answer the questions. However, all of the recommendations that were made in this review were weak. So what evidence do we have now in 2024 to support interventions for family-centered care and family engagement in the ICU? In 2016, Curtis et al. Published in the Blue Journal about an ICU communication facilitator who decreased the cost and length of stay as well as depression in family members at 6 months, but this intervention did not affect anxiety, PTSD, or 3-month outcomes. In 2016, in JAMA, there was a palliative care-led family meeting intervention, which did not impact either anxiety or depression in family members, and in fact, may have worsened PTSD outcomes. In 2017, Azalea et al. Did an intervention where they wrote condolence letters from the physician and nurse taking care of the patient at the time of the patient's death to the family members, and these letters worsened depression and PTSD in family members. In 2018, Chris Cox in the Blue Journal published a trial on telephone and online coping skills. This also did not improve psychological distress. And in 2018, Doug White et al. In the New England Journal did a trial where they trained nurses in communication skills to help facilitate interdisciplinary meetings. And this did not affect surrogate psychological symptoms either. And if you heard Doug White's research talk last year when he visited Yale, he has a trial that should be getting published soon that I was hoping to be out by now, but it's not quite out yet, which also similarly did not show an impact of another intervention to support families in the ICU. Interestingly, in Doug White's trial from 2018, they did find that surrogates' ratings of the quality of communication and the patient and family centeredness of care were, and as well as the ICU length of stay, were better in the group with the intervention. And so you may notice that a lot of these interventions have been looking at primary outcomes in PCCSF, or post-intensive care syndrome in families. And so interestingly, the Doug White's study did find that this alternative endpoint of patient and family engagement, as opposed to the PCCSF, PTSD, anxiety, depression type symptoms, it did have more of an impact in these patient and family-centered care. But overall, we've had quite a few inconclusive to negative trials in this space. And so here from Doug White's 2018 trial, you can see that while the surrogate's burden of psychological symptoms was not different between the groups, in the pink lower right-hand corner here, the intervention group did have improvement in some of those markers of patient and family engagement, including a quality of communication score, a modified patient perception of patient-centeredness score, as well as a couple-day reduction in the actual ICU and hospital stay, with the PCCSF symptoms being unaffected. And so what are we left with? Other than the 2018 trial that we just reviewed, since 2017, there really have not been any major trials in this space, and those recommendations from the 2017 review likely remain weak. And at that time, they described this area of study as nascent. So next, what I'm going to do is take a step back and take us on a little bit of a whirlwind tour of what we know about family engagement in the ICU thus far. And so we're going to start by taking a time machine back to 1961. We are staying in New Haven. This study was conducted by Esther Lucille Brown, who was the first woman to get a PhD in social anthropology at Yale in 1929. At that time, she asked 65 nurses what they would want if they were ill and hospitalized for 3 weeks. And this nurse that's quoted here said, if I were allowed to bring the thing which would give me the most satisfaction, I would bring my family. And then she notes that this isn't really realistic with the present, aka 1961 hospital structure. And she says, my next choice would be a professional nurse who would act as an interpreter between myself, my family, and physicians. And she goes on to describe how this person would go back and forth between the patient in the hospital and the family's home, explaining and reassuring the family as well as the patient. In 1972, a nurse named Ruth Craven reflected on the impact of illness in families, and she observed in the nursing literature that, quote, students in nursing are too often exposed to platitudes and generalities regarding family-centered nursing, with vaguely communicated expectations or guidance for their incorporation into the nursing plan. In 1976, in what would become a touch point for research into the role of families in the ICU, for her doctoral dissertation, a nurse named Nancy Moulter reviewed the literature and surveyed 23 nursing graduate students. From that survey, she developed 45 need statements, which were used in structured interviews with 40 family members of critically ill patients. It would go on to be widely used as a research instrument and is shown here, ranked from most to least important by families based on a later 2001 study. In the early 1990s, a nursing PhD, Jane Stover-Lesky, validated the inventory based on Moulter's findings with a cohort of 671 family members, which was used throughout the nursing literature. And in 1991, Lesky validated this survey using a statistical tool called factor analysis to identify groupings for the different needs statements. She identified 5 different groups: support, comfort, information, proximity, and assurance. But she appreciated the limitations of surveys for understanding and therefore impacting the experiences of families in the ICU. Later that year, in a perspective piece in the same journal, she wrote, "The selection of a conceptual framework does not have to be limited to currently popular theories." And she called for inductive theories and interview and observation-based theories. And so I would argue that we've had some idea of the needs of family members of critically ill patients since the 1970s and 80s. So it's not really truly a nascent field, although you could say that in the scheme of things, our understanding of how to actually impact outcomes remains quite nascent. And so as you've just seen, we have a rigorously validated survey instrument for this topic, and there have been a number of randomized controlled trials, interestingly, including one, the 2018 Doug White one, which tests that proposal of that nurse, of a professional nurse to act as an interpreter between the patient, the family, and the physicians. But these trials have been overwhelmingly negative, and so in terms of finding solutions and interventions for improving family engagement in the ICU, we are, yes, indeed, still quite nascent. And I will admit that I didn't initially realize that I had chosen an area of research that has become a bit infamous for its negative trials when I started working in this area. But we have persevered. Learning all this history raises the question of why not rely on a validated study like Moulter's. But I'm going to make the argument that this is a great place for us to turn to qualitative research. For an analogy, if a fish created a survey for other fish about what it's like to be a fish, they might ask questions like, how many fins do you have? What is your favorite food? Do you like to swim alone or to school? But they might not ask the other fish any questions about how they breathe or what it feels like to be underwater. And this is where qualitative research comes in handy. Qualitative research does not quantify variables or even test hypotheses, but rather allows us to create rich illustrations of thoughts, feelings, and motivations of the subjects. And so now what I'm going to do is turn to walking us through some different types of qualitative methodologies that can be used to guide us toward understanding phenomena and developing more impactful interventions. Each of these methodologies becomes progressively more specific and focused in its aims, each with its own strengths as to what it contributes to our understanding of a concept or an experience. And on this whirlwind tour, I will walk us through a relevant piece from the literature on family needs and family engagement in the ICU. So we're going to start with phenomenology and grounded research theory. Phenomenology is about describing phenomena. It's a methodology that is useful for understanding concepts that are not well understood, and a theory arises from the data. It is purely inductive, meaning that we don't go in with a plan or a framework of what we're going to find or be looking for in the data, but rather allow the data to reveal the theory. And so as an example of this, this is a study by Eggenberger in 2007 that was performed at a MICU at a tertiary care center in an urban area of the Midwest. They conducted 11 family interviews with 41 individual family members. And so these were group family members with one interviewer and the different members of the family all present during the interview at the same time. And these interviews were focused on the family's critical illness experience. And they were transcribed and then reviewed for phrases that answered questions related to this core question of family experiences of critical illness. And so their data is quotes, and this is an example of a quote that they found. "We don't want to leave or to go outside the hospital. I don't know, we want to stay real close. I think it's probably good for the patient to know they are not being left alone. It's hard to explain the feeling. I just have to be here. I need to be here." And so from these rich interviews with families, they developed a number of patterns, themes, and sub-themes. And I'll draw your attention to that theme related to the quote we just saw. The theme is called being on guard. And one of the sub-themes that they identified was what they called a must to be near. So that yearning of the family members to be at the bedside with their loved one, even in the midst of critical illness where that person maybe couldn't interact with them in the ways that we typically think of interacting with our loved ones. The next methodology that I'm going to review is an ethnography. And so this is an anthropological approach where historically, typically an anthropologist would embed themselves in a community, often for months or even years at a time, and they would observe. They would sometimes interview people in an unstructured setting, but primarily it was about being there long enough and just observing so that people don't notice that you're there, and you can really get some insight into a different community or culture. So the study that I'm going to share here by Scott Reeves was where two medical anthropologists conducted 504 hours of observation and 56 semi-structured interviews across 4 ICUs over 1 year. And so this is a standard level of depth and commitment of an ethnography to really be present in the environment for a prolonged period of time. And with the idea that embedding and longitudinal duration will reveal something that might not come out of shorter interactions. So for Reeves' study, they used a model of interprofessional teamwork to help organize and interpret their findings, which you can imagine with 504 hours of content, which must have been quite a bit. And they grouped that into different domains: relational, processual, organizational, and contextual. And you may be unsurprised to know they identified a lot of themes given the depth of their study. And so while their initial framework was centered around interprofessional collaboration, they identified the relationship between the family member and the care provider as a central theme. In their interviews, they found that each family member had developed a really positive relationship with at least one of their care providers. And factors they identified as contributing to trusting relationships were a knowledge of the patient's history and frequent and informal communication. And so obviously not all of us can spend a year embedding ourselves in the environments we wish to study. And so there are focused approaches which use the strengths of an ethnography, but to try and distill it down to the elements that can allow us to get as much data and nuance without having to put that time commitment in. And these often use sequential design that includes observation as well as shadowing in interviews, so that you are getting data from different environments to kind of, and context to get more from a shorter duration of time. And so this study done by Emily Bolte with Dina's lab was an ethnographic field work in a 20-bed ICU at the University of Michigan. And they conducted 17 and a half hours of observations, shadowed 6 ICU clinicians, and then did 12 semi-structured interviews with both clinicians and families. And using that same methodology of coding the interviews, themes were revealed from the clinicians, the family members, and the observations. And so what Bolte found was the first theme was that family factors influence the information sharing process. Clinician strategies support engagement in the information sharing process, and that information sharing builds trust and relationships between families and ICU teams. As a final methodology to touch on, I'd like to talk a little bit about some of this health services specific research approaches. These often are mixed methods, meaning that they start out with qualitative approaches like we've just reviewed, but then move into more quantitative analyses as a second part of the same project. So often this might be something like starting with interviews and then moving toward a survey. They often include interviews or focus groups that are more targeted than an open-ended observation or interview that help further elucidate the understanding of whatever the topic being studied is. And so this study by Jackie Cruiser is interesting. It looked at 26 patients with critical illness and then 26 patients who had died. And they did a qualitative analysis of text from the electronic medical record. And so instead of coding interviews or observations, they coded the electronic medical record directly. And they coded anything that was talking about decision-making, prognostication, resuscitation status, goals, values, preferences. I'm not going to say goals of care because Jackie Cruiser has a very compelling argument for why we shouldn't be using that phrase in particular. And based on those that coding of those records, she developed a model to describe what I'm sure will be familiar to all of us as a common ICU trajectory. They found that a patient would be admitted to the ICU to receive an intervention and would receive the intervention that was intended based on their physiology. And then those interventions would, as they so often do, fail to improve the clinical status of the patient, and they would go into physiologic or multi-organ failure. And at that point, and only at that point, were the patient and the family really engaged in the process. And so why studies like this are helpful and interesting to us is that if we designed an intervention that only occurred once that patient and family engagement stage has been reached as it's currently designed, we might actually miss out on opportunities to conduct an intervention when it's more effective, maybe a little bit earlier in this process. And so I hope that I've convinced a room of likely very quantitatively oriented folks that qualitative research is key to understanding the complex dynamics of family engagement in the ICU. But where do we go from here? And how do we move from themes and processes to interventions? And these qualitative findings can help in that next step of building a model that defines and summarizes the findings. And from that model, it becomes more apparent what potential interventions might be impactful. And so I'll just remind you that this was the first model we saw that was based on a survey, which is an example of a quantitative methodology. Since then, there have been some additional models proposed to help guide this process. This is one example that arose out of a 2016 review of the literature, where they proposed a continuum of family involvement from most passive to most active. And you can see that over the 25 years or so since the Lesky model, the role of families in decision-making and a transition to family involvement, as opposed to just meeting family needs, has developed. And around the same time as that previous model, Sam Brown out of Intermountain Health proposed a model as well that was developed using a modified Delphi technique. And a modified Delphi technique is a structured process for coming to an expert consensus. So this is essentially expert opinion. And this model introduces the idea of respect and dignity, which is somewhat related to the idea of support proposed by Lesky, but I would argue it's more comprehensive than that. And it also defines the concept of collaboration a bit more broadly, not only as direct patient care, but also at the hospital and the systems level. The one thing that is consistent across all of these models that I've showed you thus far is that family engagement definitely has 5 components. And so while we still don't have an evidence-based definition of family engagement in the ICU, what we wanted to do was come up with a definition. What is family engagement anyway? And so to better define what family engagement actually is, we turned to the people who are directly involved, clinicians and families. And so for our project, we used a focused ethnography and a sequential qualitative design with observation, shadowing, and interviews to understand team dynamics and family engagement in the ICU. So Dina and her team performed these observations and shadowing and interview at the University of Michigan, as well as community hospitals in the area, and these were prior to COVID. And unlike many of the studies we've reviewed just thus far, she gave equivalent attention to the role of clinicians as well as families. And so using these transcripts, working with Dina's qualitative team, I performed a qualitative framework analysis of the data, which is a specific qualitative methodology that's well suited to health services research. And unlike the scientific method where we separate out each stage of the process, and that's really essential to the rigor of the scientific method, in qualitative research, it's okay to go back and forth between the stages, including in framework analysis, which is really a very iterative process where a code you develop your codes and may develop a model that may inform other codes that you haven't thought about that then help you refine that framework. The framework analysis in particular was developed about 25 years ago in the public policy space, and it's very focused and targeted. In phenomenology, the analytical framework arose out of the data, and the framework is your end product or result. In a framework analysis, you can rely on an existing framework and then chart your data into the framework. And so we use the framework that we just reviewed, proposed by Brown et al., with the 5 components of information sharing, respect and dignity, collaboration, activation and participation, and decision-making, to see if we could validate a model that had been developed via expert consensus in the data. And so we did identify the themes proposed by Brown. Information sharing is really about patients and families receiving and providing information about patients and their care. And I think it's often the one that is most obvious to physicians as an important part of the family's role in the ICU. Collaboration is about clinicians and families partnering at every level, and this involves in direct care, but it also is about partnering at the hospital systems level. And so this could include having patient stakeholders on boards and committees within the hospital, for example. Respect and dignity is about respecting the patient and family goals and values and treating patients and families with compassion. Activation and participation, which has been robustly studied in the nursing literature, is about engaging patients and families directly in patient care, oftentimes at the bedside. And finally, decision-making involves including patients and families in decision-making at the level of their choosing. And we also identified 3 themes that had not been described by Brown or previously in the literature. Some of these had been identified to some extent in previous work in both qualitative and quantitative literature, especially in the nursing literature. For example, Moulter's survey data described needs like having access to telephones, bathrooms, food, and help with financial problems, as well as the primacy of honesty as a family need. Reese's ethnography identified the importance of building a family-clinician relationship of trust. And Bulte's focused ethnography also identified information sharing as a means of building trust and relationships between families and the ICU team. What is more novel is our emphasis on the bi-directional relationship. What we found is that for family engagement to be successful, not only did family needs need to be met, but clinician needs needed to be met as well. Families not only needed to have trust in their team, but the relationship between the family and the clinician had to be one of trust for both of them. And poor communication and conflict did not only occur between patients and families and their ICU team, as many of you may know, it could also occur within families or between the primary ICU team and the consultants. And all of these miscommunications and negative interactions impacted family engagement. But you don't have to take my word for it, so I'm going to show you some quotes that show the bidirectionality of these relationships. And so this is a quote from a nurse who had a miscommunication with a family member about how many liters of oxygen the patient was getting. So the nurse was telling the interviewer about the occasion, and they said to the patient, "I'm sorry you feel that way. This is why I did that." He, the family member, wasn't even receptive to hearing me the next day. And I came in and I said, "I apologize. We had a miscommunication. I didn't tell you what I was doing and why I was doing it, and that was my fault." And then the patient apologized to the nurse. And so the nurse chose to share this episode with the interviewer, and it was very important to the nurse that not only did they apologize to the family member, but the family member reciprocated and apologized as well. And so by doing so, they were able to repair the relationship and reestablish trust. And interestingly, this family member also asked for forgiveness, but for a very different reason. And so they had an adult child with chronic critical illness who had been hospitalized multiple times. And during a bout of feeling frustrated with the medical team, their perspective changed. They told the interviewer that they said to the team, "I need to ask your forgiveness for that because I have been worried about your knowledge. And I realize that you have all the knowledge you need. You need wisdom. And that's how I'm going to pray for you from now on, is that you have wisdom." And so for this family member, they realized it wasn't that they didn't trust their team's medical knowledge, but that they felt that the team didn't necessarily have the wisdom to care for their daughter. And so finally, this is a quote from an attending who was observing the impact that challenging dynamics with families had on the physicians, on the residents and fellows, and the care that they therefore provided, and that they would try and boost up their team. And so they would say things to the team like, "We feel we're doing things that are not going to change the outcome of a patient. And it impacts the emotional well-being of the team." And they would say to their team, "I know you're being berated, to be honest with you, and it's hard to do your job when that's happening, but kind of try." And so what we found was that there was an assumed or implicit model of the patient and family engagement in the prior research, one that looked like this. Clinicians could provide patient and family engagements to patients and families, and that was almost like a service that we could provide. But what we found in the data was that patient and family engagement is actually a bi-directional relationship. It relies not only on how the patient and families receive the clinicians, but also how the clinicians are impacted by the family. And for it to be successful, both parties need trust, honesty, and rapport. And so it's possible that interventions that don't attend to the bidirectionality of this relationship may not be as effective. And as anyone who spent any time in the ICU knows, these relationships are not actually bidirectional, but they're multidirectional. And they involve a whole host of people in relationship with each other in all sorts of ways. And so I hope I've convinced you that patient and family engagement in the ICU is a multidirectional relationship. And so from here, where do we go next? So we have multi-center data from University of Michigan and Yale to further define the network of people, which will include palliative care and chaplains who interact with patients and families over the course of their ICU stay. And we're going to explore more deeply this idea of trust, honesty, and rapport in the ICU. And so we have detailed shift level data from Yale on clinician interactions with the patient and family. And are interested in looking at the continuity of those teams. And so, for example, our team, do patients that have more continuity build more trust with their providers? Are they more likely to have changes to their code status? More broadly, we are considering ways in which we might be able to support both families and clinicians in building these multi-directional relationships. There is some early research in both the qualitative and quantitative space supporting this idea that trust and honesty from the clinicians are essential for families' experiences in the ICU. In particular, the role of distrust in the medical system amongst minoritized groups due to racism and systemic bias. But most of the interventions thus far have either focused on disseminating information to families through things like family meetings or family-centered rounds, or bringing in additional team members like the supportive nurse to go between families and patients. And so we're interested in exploring how this idea of trust, honesty, and rapport could potentially underlie more successful interventions. And so that's all I have. So I just want to make a big thank you to Dina for her amazing support and guidance throughout this process. And thank you to the whole qual team in her lab, especially Nate and Hanji, and then Kathleen, who's here in the audience today. And then, of course, thank you to Dr. Ferrante, who reviewed my talk with me and gave wonderful feedback, Dr. Koff through his guidance throughout the research process, and Dr. Kaminsky, Dr. Hunniden, and Dr. D'Ambrosio. And we'll open it up for questions. Yes.
Question.
You get the honor of running around.
Yeah, it's fine. Perfect, thank you.
Awesome, that was a great talk, Ella. This was a space that was near and dear to my heart in residency and fellowship as well. And I felt like your point was great. Like I didn't know I was entering a field with all these negative results, right? So I guess my question is, why do you think that all of these like studies that have been done of these interventions, why have they had negative results? Point one. Question two is, if you had to design an intervention, what would that look like? And what should the outcome really be that we're looking at?
Those are the two big questions. So I'll do my best to answer them. So in terms of why the prior studies were negative, appreciating that many people have a lot more experience in this space than I do, but based on what I found in our interviews, was it felt like a lot of times the interventions were trying to add components like a letter, a family diary, an additional support person, instead of addressing the existing relationships between the providers. And my hypothesis would be that it may not make as much of an impact how many additional wonderful interventions you have if that relationship that you have with the care team is not one of trust. So that'd be the first question. The second question is, what do you do then about it? And this is a question that I've been like grappling with, like, oh my gosh, like what would the intervention be? I can't think of something, what am I gonna do? And that reminded me that when we don't know what to do, going back to the data, which in this case is patients and families, is the answer. And there's some really interesting work being done in co-designing interventions. And so using focus groups not only to ask people what their experiences were like, but actually design studies with them. And so I think this is an opportunity to actually directly partner with patients and families as researchers. They're subject matter experts and may have ideas that we, as the fish in the sea of the ICU, will never see.
So I just want to echo Sandy's point. First of all, great talk. And, you know, I think that in looking back, particularly on like Randy Curtis's study, I think this notion of having some external group come in and do this for you in a structured way is I think part of the problem, because if I'm reading your interviews correctly, what it looked like families were really seeking was much more informal than that, and particularly direct access to the people they entrusted their loved ones' lives to. And so it leads me to my question, which is that, I understand the notion of this qualitative research not being beholden to a hypothesis, but as a future attending, you're also not a blank slate, right? You've been a student, resident, fellow, you're soon going to be an attending. And so I have to imagine that in your experience, you have seen good examples of family engagement that you might want to emulate, and you've probably seen some that are problematic. So what have your observations been? Like, so what do you see on the ground in your clinical experience that might in turn inform the research and then hopefully interventions that you would seek to propose afterwards?
Yeah, so I think we all have both observed bad, maybe difficult interactions, unsuccessful interactions, and positive interactions, and we've also both had them. And what I notice when I have an interaction that feels like I didn't reach that place that I wanted to reach with the family, not in terms of achieving a certain outcome, but in terms of connecting with them, that it's really about that trust. And that resonated with me, this idea of trust and how do we build trust. I think one possibility is that you can build it longitudinally. And I think many of the clinicians here have had those experiences where your day one or even your day 2 and day 3 interactions, you don't feel like you've gotten that trust, and it's challenging to work with a family. And sometimes on day 4 or 5 or 6, you are actually able to demonstrate, I think that you have the skills, that the competence to do it is a foundation. It's necessary, but not sufficient. I think a lot of times there are families that are looking for a demonstration of that, and that you care, that you are a professional who is invested. And I think that's foundational. If you potentially have some of what we call like the soft skills, but without those things, I'm not sure it always can make up for that foundation. And then in terms of building that trust through the interactions with the families, I think there are some systemic challenges that need to be addressed on a systems level and are not possible for individual clinicians to necessarily overcome, and expecting us to be able to ourselves to be able to do that. I think we can give ourselves a little bit more grace that sometimes it's not about us, and there are bigger picture things that may be driving that distrust. But then other times, I think that the part of the bidirectionality is about being ourselves, and sometimes that means that we have to let our guard down and not play the role of a doctor. And that I think my most successful interactions with family have been where I'm able to be vulnerable with them and honest not only about their loved one's prognosis, but honest about what I don't know and what I can't fix. And that is a skill that may be easy to talk about developing, but is very hard to actually do. And I'm not sure what the intervention would be that would develop that at scale rapidly across clinicians would be. But I think it is a place where turning to families may give us some things to think about, because I think that they really do appreciate when we are humans bearing witness to their loved ones suffering with them.
Yeah, I mean, just in follow-up, I think you're onto something really important here. And so if I could just share my own observations, I'm really impressed with our fellows. And I really think that in some ways, we're in this sort of strange period right now where a lot of our junior people are getting very sophisticated training and communication skills. We have the expert input of palliative care, we're doing workshops and SIM training. And so some of the best communicators and people who I think connect particularly well are actually people who are just starting out. And I think rather than this sort of farming out an intervention of other people to do your communications for you, that the theme I'm hearing from you is that this is has a lot to do with professional development. And then just a follow-up, Shoko's heard me say this a number of times, but I think it just is important to say, we're actually more restrictive about visitations than we were many years ago. Only 2 were allowed in the room, not till 10 a.m. I would vote that we should go back on that. And I also think we need to have longer rotations.
Interestingly, I appreciate you bringing that up. Open visiting hours are evidence-based and recommended. And interestingly, in the conversations that I've had, mostly like informally, for example, at ATS, physicians would say, oh, nursing won't let us open up visiting hours. And then I would talk to the nurses, and nurses would say, physicians won't let us open up visiting hours. So just food for thought, that maybe we're cross-talking a little bit, and there are opportunities to expand that part of our evidence-based care.
Oh, that was excellent. I walked in a little bit late, but it was right at the moment when you were going through every single one of the negative trials on the outcome. And I just wanted to ask you a little bit about that outcome for most of those trials, because it seemed like they were trying to mitigate psychological distress of the family. And I started asking myself, are we asking the right question? They're having a family member die, and grieving is part of that process. And should we be targeting other endpoints in some of these trials? And that's part one of the question. The second part is, I have found having family members join rounds to be invaluable. I think they are dumbfounded by the amount of detail that we go through and the amount of thought that goes in. I was just curious if that single intervention has been studied on outcomes in patients.
Yeah, so I'm going to address your second question first, because I think it's easier to answer. So there is pretty robust evidence for family-centered rounds in the ICU. One of the reasons I didn't focus on it in this talk is because physicians love family-centered rounds. And I love family-centered rounds too, but I think the conversation cannot end there. And I think it relates to our default to the information sharing part. That's where doctors are comfortable with information. And so we like talking about family-centered rounds, because we feel like if we give families information, they will feel engaged. And so for a room of mostly physicians, I focus a little bit more on the other parts. But I agree that they're very valuable. In my experience, the key components to successful family centered rounds, just anecdotally, are explaining to the family that we're going to be talking shop at first, and that they may not understand much or any of what we're saying, but they're welcome to join and listen and hear our process. I think trying to run family-centered rounds where you are talking in lay people's terms, and this was said by actually some of the interviewees in our study. There's a reason jargon exists. It allows us to communicate, and when that's taken away from us, it becomes very difficult to communicate our medical knowledge, information, and decision making, while also trying to talk to families. So I think separating it out. We're going to talk shop for a bit, and then at the end, we'd love to answer any questions that you have, or we'll come back around. And I think that is key. I don't have as much of an answer. There are cases where there are things that you may not feel comfortable talking about in front of families. I think most of those situations, we actually should be talking about those things in front of families, even if it is uncomfortable for us. And it's quite rare, the occasions where we really shouldn't be. I think we, and the interviews support this, that we feel inclined to sugarcoat things or couch them in certain kind of language, and families actually perceive that often as not as dishonesty or not trusting them. And so even when it's uncomfortable for us, being honest with them is what people want, especially when they know that it's coming from a place of care. To your first question about outcomes, I think the question of psychological distress is challenging, and I'm not as familiar with, I think, like the trauma literature, which is probably where I would go to really understand what is an appropriate response and what is potentially interfering with their ability to cope and live their life following an ICU stay. I do think that patient and family engagement is a different question than post-intensive care syndrome family, and looking at them separately makes sense. And a lot of the studies thus far, patient and family engagement has been a secondary outcome. And so I wonder whether pivoting more toward making that a primary outcome and really designing interventions that are focused on engagement will result in improved outcomes for the family engagement component. And as someone with very little to no expertise in this space, I wonder whether having some of that autonomy and control in the process that comes with being directly engaged, providing direct care, participating in conversations, having a trustful relationship. If we focused on patient and family engagement as our primary outcome, maybe we actually would see some improvement in some of the psychological distress components.
So this is a very tough, intriguing area to work in, and I admire your willingness to go in this space with Dina and others. I have a couple of thoughts or questions that have troubled me over the years. One is that we often would find that the patient wasn't able to communicate with us because maybe they were on the ventilator and they were sedated. And then we would turn to the family members and say, well, what do we think that our patient would like to have or not have in this area for care? And I've always found that often, a very big challenge. The second kind of question or comment I'd like you to mention, I think Dina's worked very hard in this area. It's about continuity. And what do we know about the limits? We're at an academic center, and many of our fellows who are listening in today, candidates, are at academic centers where this is an issue. We have these rotations that are limited to sometimes for attending a week. And how can this problem of continuity be addressed? And it's okay if Dina wants to work with you in answering that.
I'll take a stab and then I'll definitely pass the mic. For the first question about those challenging conversations and talking to families about what their loved ones would want, I find kind of two things that I keep in mind when I'm having those conversations. The first that I try and do is solicit information about who that patient was. And I love it when I'm able to learn about them as a person a little bit from a family. One family I spoke with once was the mother was kind of bereft that her son couldn't eat in his final days, and just talking to her about what his favorite foods were was really meaningful to them and to me. And it was a Korean American family, and hearing about the bibimbap that was like so crucial to them, like not only told me about something about who he was and allowed me to connect with the mother, but also helped me understand what was important in his end of life care, and allowing him to eat was a top priority. And so not just saying what would you want in terms of your medical care, but who are they as a person. And then from that conversation, I learned a little bit about them, and I also developed that trust with the family that I'm interested and care about their loved one. And from there, I try and make recommendations, and I often ask permission to be honest with them. Is it okay if I'm honest and open with you? Which is a little bit of a warning shot that some tough news is coming. And then I say I'd like to based on everything you told me, I'd like to make a recommendation. There are multiple options of what are reasonable things to do, but based on what you've told me about your loved one, this is what I think might fit best. And then I say, if you don't think that's right, let's go back to the drawing board and talk about it more. And I think it can be really hard to do, especially when they're not easy decisions, because I have to take responsibility for that call a little bit more than if I just said, what do you want to do? And there have been times where I lay in bed at night thinking, did I make the right call? Like, I made a recommendation and was it the right one? But I would rather I be laying in bed worrying about that than the family. And I think we've swung a little bit so far into this idea of autonomy and that families should make every single decision. And it's not that we're taking away their autonomy. They are the expert on their loved one, and I'm the expert on the medical interventions. And so using their information about their loved one, I can help guide them. So that's for your first question. For your second question about continuity, there's a really interesting study that I present here where they looked at distrust in medical providers across days of care. And among nurses, each day that a family worked with the nurse, they developed more trust in the nurse. Among physicians, it didn't matter. So you can kind of make of that what you will. But I do think it gives us an opportunity to say, okay, we can keep duty hours. We can still give their interns their day off. It's not actually affecting the trust. And maybe if we work in some of these things like Dr. Siegel is talking about how to build that trust, because it sounds like you kind of get one chance as a doctor.
Keep the nurses there, rather.
Yeah, no, that's great. And I think continuity is really important. And I think, so Ella had mentioned a little bit of some of her next steps, which will include sort of looking at the continuity of the teams with data that we're getting from Yale, which I don't know if any of you have dealt with JDAT. Getting the data from the electronic health record has been a long time coming. So we just got that data. So we're getting updated as we speak. And so Ella will be able to dig in there and take a look at whether having more continuity for nurses, for physicians, for all of them might be associated with shorter time to code status change for patients that have died in the ICU, which I think it's a little indirect, right? Because it's a secondary analysis, but it's getting at, is there theoretically better communication when there is more continuous teams? But there's probably a threshold, right? Like, I mean, the family there's personalities, right? Like there's lots of things that come into play. And I think sometimes if there's difficult communication, that could lead to more burnout. And right, like there needs to be a lot more work in that space, in my opinion. Yeah.
Maybe we do one more question. It's right up here.
Oh yeah, sorry, I didn't see you.
This is teamwork in action.
Yeah.
Amazing talk. You crushed it. You mentioned a little earlier, and I apologize if you actually explained this and I just missed it because of my lateness. But you said we shouldn't be using goals of care anymore as a phrase, and as a fellow patient-centered language nerd, I would love to know if you can say in like 20 seconds why and what I should be using instead.
Yeah, Jackie has a really amazing like hour-long talk on like arguing against the term. I think basically it just becomes like it's called like a wastebasket term. And it's a little bit code for code status. And code status is code status, and comfort measures is comfort measure, and goals of care is kind of what we say when we want to pretend that we're talking to the family about goals and values, but are actually just talking to them about limiting interventions. And that being more specific in our language, as you are already convinced, allows us to provide better care.
So I should just say what I mean.
Yeah, but it can be uncomfortable. So I think there's a reason that we've developed some of these workarounds, and it can take more effort and emotional demands on the provider to be honest or to not sugarcoat terms. And in order to do that, we need our basic needs met. It's really hard to have, as I'm sure we are all aware from our home lives, that when you're hungry or sleep deprived, you may not be your most authentic, vulnerable, compassionate self. And if we want to or need to show up for our patients in those ways, we need to have our oxygen masks on first.
Awesome, thank you.